Good afternoon, I'm Laura Chatterton. I'm the student nurse practitioner who's going to be performing your musculoskeletal examination. We're going to start with the temporal mandibular joint in the face. I'm going to inspect while I do this for facial symmetry, looking for any swelling, redness, or tenderness at this joint. I'm going to place my fingers just in front of the tragus of each ear and ask the patient to open and close their mouth. Excellent. While I do this, I want to make sure that my fingertips drop into the joint spaces, again checking for swelling, tenderness. Any snapping or clicking can be a normal finding, however. I'm also going to palpate the muscles of mastication, which include the masseters, the temporal external muscles. So I'm going to ask the patient to clench and then relax their jaws. And then the pterygoids, which are internally between the tonsillar pillars at the mandible level. For range of motion, I'm going to ask the patient to open and close their mouth. For protrusion and retraction, I'm going to ask the patient to thrust their lower jaw out and then back in. And then I'm going to ask the patient laterally to move side to side. For this particular joint, there's no strength testing that's required, so we're going to move on to the neck. With the neck, once more, I'm going to check for symmetry, looking for any obvious masses, scars, or lesions, looking for any enlargement of any glands or lymph nodes, checking for placement of the trachea and also for the thyroid gland. For range of motion for the neck, beginning with flexion, I'm going to ask the patient to chin to the chest, to bend. For extension, I'm going to ask the patient to look up at the ceiling. For rotation, I'm going to ask the patient to look side to side over their shoulder. And then for lateral movement, I'm going to have them bring their ear to their shoulder on both sides. To test for strength, I'm going to ask the patient to press against my hands on both sides, noting for this patient the strength in the neck is 5 of 5. Moving on to the shoulders, I want to first start by inspection, looking for any obvious swelling, deformity, atrophy, any fasciculations or abnormal positions. I want to look for the swelling of any joint capsules either anteriorly or looking for any bulges in the bursas. I also want to check the skin for any color changes, alterations, or any unusual bony contours. To begin, I'm going to start at the sternoclavicular joint, and I'm going to trace the clavicle laterally. I could move it up and down, but we're not going to do that for today. I'm going to, as I get to the lateral aspect, look for where the acromioclavicular joint is, and from there I'm going to move my fingers down into the infraclavicular fossa. I'm going to ask the patient just to put their arm out, raise it up and down just a little bit, please. Up and down, thank you, so I can feel that I'm right in that fossa. I'm also going to move now where that fossa is, coming up to the actual aspect of the humerus. I want to palpate that whole area. I'm going to actually grasp the lateral aspects of that and palpate for the greater tubercle. I'm going to ask the patient just to raise their arm up, down, and back, and I can feel that range of motion there. I'm also going to inspect the back, the scapulary spine I want to feel. I'm going to move down and note the lateral border as well as the angle of the scapula, and then coming up the medial border. For this, I'm going to ask the patient to stand up, and for range of motion for our shoulders, we're going to do flexion, where we're going to raise the arms up in front and overhead. This is a 0 to 180 degree angle movement. Then I'm going to ask the patient to raise their arms behind them. That's a 0 to 60 degree angular movement. For abduction, I'm going to ask the patient to raise their arms out to the side and then up and overhead. For adduction, I'm going to ask the patient just simply to cross their arms in front of them. And for internal rotation, I'm going to ask the patient to put their hand behind their back and touch their shoulder blades on both sides. And then lastly, for external rotation, I'm going to ask the patient to raise their arms to shoulder level, bending the elbows for 90 degrees, and then rotate like this, please. Rotate their arms upward for external rotation. For strength of the shoulders, I'm going to start with the external rotation lag test. I'm going to have the patient bend their arm at 90 degrees with their palm up, and then we're going to rotate the arm out for a full extension rotation. That is the external rotation lag test. For the internal rotation lag test, I'm going to have the patient place the dorsum of their hand on their lower back with their elbow flexed at 90 degrees. Then we're going to lift the hand up and off the back and keeping the hand in this position. Just note the strength of that. For both of these, the patient was a 5 out of 5. And lastly, we're going to do the drop arm test, where I'm going to have the patient hold their arm out to their side and slowly lower their arm down to their side. This would be a 90 degree down to 0 degree movement. We're also going to test for the near impingement test. I'm going to press on the scapula and ask the patient to raise their arm. If there were any pain, that would be a positive test, and it would indicate possibly rotator cuff tendonitis. Second, we're going to do the Hawkins test, or the impingement sign test. We're going to ask the patient to have their arm bent with their palm upward. I'm going to place my hand on, we're going to go up, thank you. I'm going to place my hands as such. I'm going to move the patient's hand internally. Bend that a little bit more, please, thank you. And if there were any pain with this Hawkins test, then we would know we have a rotator cuff impingement. Lastly, the empty can test. I'm going to have the patient put their hands out at 90 degrees, thumbs down and internally rotate. I'm going to push against that. The patient resists, and again, we have a 5 out of 5 strength for that particular test. Moving on to the elbows. Once more, the inspection process, I want to note for any obvious abnormalities or displacements. I'm going to be inspecting the contours of the elbows, both anteriorly and posteriorly. I'm going to be checking for the olecranon processes, noting any nodes, any swelling, redness, or warmth. To palpate those, I'm going to just have the patient bend a little bit so that I can feel for the medial and lateral epicondyles. I'm also going to be palpating for the grooves between these and the olecranon process, where the synovium is the easiest to palpate. I'm going to palpate for the ulnar nerve posteriorly between the olecranon process and the medial condyle, and I'm going to check for any displacement of that. For range of motion, flexion, we're going to begin with by having the patient just bend their elbows. Extension is straightening them. Supination, I'm going to have the patient with their palms up as if they're carrying soup. And then for pronation, simply turning their palms down. For strength, I'm going to have the patient bend their elbows again at 90 degrees, both of them please, and they're going to resist. And then to test for extension, I'm going to have them push down. Excellent. For supination and pronation, I'm going to have them move their hands back and forth while I feel for the strength and try to resist the movement. For this patient, we have strength in all positions, 5 out of 5. Wrist and hands are next. Once more, I want to inspect these, looking for the position of hands in terms of their movement. Fingers should be relaxed, slightly flexed. The fingernail edges are roughly parallel to one another. I want to check both the palmar and dorsal surfaces of the wrist and hands carefully for any swelling or trauma. I'm going to look for any obvious deformities of the wrist, hand, or finger bones. I'm going to check the contours of the palm and then check for any thickening over the flexor tendons or any flexion contractions of the fingers. When I palpate the wrist, I want to palpate the distal radius and the ulna of the lateral and medial surfaces. I'm going to palpate the groove of each wrist joint where the thumbs on the dorsum of the wrist. I'm going to be checking for any swelling, bogginess, or tenderness. I'm going to palpate the styloid, the radial styloid bone and the anatomical snuff box, which is this little hollow depression distal to the radiostyloid process formed by the abductor and extensor muscles of the thumb. I'm going to palpate the 8 carpal bones lying distal to the wrist joint, and then the 5 metacarpals, the proximal, the middle, and the distal phalanges. I'm also going to palpate any suspected areas of abnormalities. I'm also going to palpate the MCP joints by squeezing from side to side between my fingers, ideally between the thumb and index fingers, but I'm going to actually be trying to note for any swelling, bogginess, or tenderness. I'm going to examine the fingers and the thumb. I'm going to palpate all medial and lateral aspects of each of the fingers using, again, my thumb and index fingers, noting swelling, bogginess, tenderness, or bony enlargement. and any swelling or inflammation of the tendons. For range of motion, I'm going to have the patient palms down, point fingers towards the floor, extension, fingers towards the ceiling. Adduction is palms down, fingers out for abduction, and adduction is bringing them in. For strength testing, I'm going to have the patient grab my 2 fingers and give a squeeze. That test does strength, 5 out of 5 for our patient. Tests for potential carpal tunnel syndrome, I'm going to start with the Tinel sign, where I'm going to tap lightly over the nerve that's in the carpal tunnel region. I'm going to be feeling and noticing for any pain. If the patient expresses pain, that's a positive test. The fail sign, I'm going to have the patient hold their wrists in flexion for 60 seconds. Any pain or numbness or tingling would be a positive test. Both of those indicative of carpal tunnel syndrome. Next, I'm going to have the patient lie down flat. While the patient is changing positions, I'm going to be observing for their gait. With their gait, there are 2 portions to it, the stance and the swing. The stance includes the heel strike, the foot flat, the mid stance, and the push-off. This is where the patient is bearing the weight, versus the swing, which is when the foot is moving forward and there is no weight. I also want to look for the arm swing, noting that when a patient puts one foot forward, the opposite arm will likewise be forward, and that will be doing in a symmetrical fashion. Arm swing actually helps reduce the energy associated with walking and improve stability of gait. While I check this, I'm going to be palpating the also anterior portion of the patient's thigh. Their hip. I'm going to be feeling for the iliac crisps, the iliac tubercle, the iliac crest, knowing that it lies at about the level of L4. I'm going to be looking for the anterior superior iliac spine, the greater trochanter, and the pubic tubercle. From the posterior aspect, I'd be palpating the posterior superior iliac spine, the greater trochanter, the ischial tuberosity, and the sacroiliac joint. I would also be feeling for the inguinal ligament by having the patient place the heel onto the opposite knee, and I would feel for that. I'd also be feeling the associated bursa, the psoas bursas, which is deep within the inguinal ligament, and I'd be palpating on the back side the trochanter and the ischiogluteal bursas, feeling those for any inflammation. Hip range of motion. For flexion, I'm going to ask the patient to bend their knee to the chest and pull it up. For extension, I'm going to ask the patient to move their leg down flat, move it away and down the side of the exam table. For adduction, I'm going to ask the patient to move their leg away from midline, so move their leg out from the hip with the knee straight. And adduction would be the opposite, which would be pulling that leg towards midline. For external rotation, I'm going to have the patient lie flat. They're going to bend their knee. They're going to turn their lower leg and foot across the midline, moving it like that. External rotation is they're going to move away from midline. This patient has good range of motion with their hips. Next, I'm going to ask the patient to get onto the chair. We're going to go onto the knee inspection. Once more, during the inspection process, I'm checking the gait for smooth rhythmic flow, for alignment and proper contour of the knees, looking for any bow-legged or knee-knocked signs, any atrophy of the quad muscles, any loss of hollows around the patella, and any swelling in or around the knee. As I palpate with the patient on the edge of the table and their knees flexed, I'm going to be feeling the tibiofemoral joint area. I'm going to be feeling the medial and lateral menisci. I'm going to also be feeling for the medial and lateral joint compartments. I'm going to be feeling for the lateral compartments, for the patellofemoral compartment, which is also going to allow me to check for the patellar tendon. When a patient is able to extend their knee like this, I'm going to compress the patella and move medial and laterally, assessing for any crepitus or pain. I'm also going to palpate the suprapatellar pouch, the prepatellar bursa, and the answering bursa. I'm also going to palpate the joint for any possible effusions. For range of motion, we're going to start with the bend or flexing of the knee as our patient is right now. Next is the extension, which is the straightening of the leg. The internal rotation is while sitting. I'm going to have the patient move their leg towards midline. And for external rotation, they're going to move away from midline. The McMurray test is next, and with the patient lying down, I am going to grasp their heel and flex their knee. I'm going to actually feel the medial aspect or the medial meniscus. This is a test, by the way, of a meniscal tear. By putting my fingers here over the medial aspect of the knee with my thumb on the lateral aspect and my other hand holding on to the heel, I'm going to move the heel externally, rotate the lower leg away as I'm going to have them push. Good. And to do the other side of the lateral meniscus, I'm going to use the same maneuver, and I'm going to actually have the patient bend and flex, and on this I'm looking for any click or popping, which would indicate a positive test for a tear of the posterior portion. Next, I'm going to check for the MCL. This is the valgus stress test or the abduction stress test. Any pain here could indicate also a complication with the medial collateral ligament. With this, I'm going to have the patient raise their leg. I'm going to keep one hand under the ankle, and I'm going to push medial against the knee while I pull the ankle laterally to the open knee joint on the medial side. Again, any pain would indicate a possible tear or problem with the MCL. On the LCL, which is the varus or adduction, same position, but instead I'm going to actually move my hands, and I'm going to push laterally against the knee and pull medially with the ankle. Let's do it on this side. I'm going to push laterally while I pull medially to the ankle. Very good. Any pain here would also indicate a gap in the lateral joint line and a possible problem with the LCL. Lastly, the posterior drawer, while the patient is lying flat, hips and knees flexed at 90 degrees, I'm going to cup my hands around the knees with my thumbs on the medial lateral joint line and fingers behind it. I'm going to thrust quickly back, pushing back on the tibia posteriorly and observing for the degree of backward movement on the femur. A positive test for this would indicate that the proximal tibia falls back. On the ankle and feet next, I'm going to inspect by checking for any deformities, nodules, swelling, calluses, or corns. I'm going to palpate with my thumbs the entire anterior aspect of each foot, checking for bogginess, swelling, or any tenderness. I'm going to feel the Achilles tendons for any nodules or tenderness. I'm going to feel the heel for the same findings, the medial and lateral aspects of the ankle ligaments, the medial and lateral malleolus. I'm going to check the metatarsopharyngeal joints for any tenderness by compressing the forefoot. I'm going to check the head of the metatarsals and the grooves between them with my thumb and index finger. And for range of motion, for flexion, I'm going to have the patient point their foot towards the floor, point their foot towards the ceiling. For extension. For inversion, I'm going to actually take the heel, bend it inward. For eversion, I'm going to bend the heel outward. All right, next we're going to do our spinal inspection. While the patient gets in position, I'm inspecting for posture. I'm checking also for symmetry of structures affiliated with the back, such as the scapula. I want to see that there's smooth coordinated movements with the neck and all areas of the spine. I'm going to palpate for each of the vertebrae in the cervical region, which is noted here by the concave area associated with the neck. As I move down the thoracic spine, I note here there are 12 thoracic vertebrae. It accounts for the convex portion of the back. Again, moving down, the lumbar region is where we have another curve inward. We have L1 through L5 here. The cervical spine, by the way, has a total of 7. And then lastly, we have our sacral region, which is S1 through S5. 3 to 5 are fused. And then lastly, our coccyx. To test the range of motion for the spine, I'm then going to have the patient bend forward and touch their toes. I'm going to have them bend back as far as they can go. I'm going to have them rotate side to side from the waist while we hold the hips steady. And then the same, the lateral bending, bending side to side. Very good. This patient has full range of motion. And lastly, we're going to do the straight leg raise, where we're going to have the patient lie flat, the leg extended. We're going to move up. This would be a test for a herniated disc, noting that pain would be found mostly at 30 to 70 degrees. Thank you so much, and I hope you've enjoyed this exam.